reducing the research policy gap. The first of these, held last month, was looking at the gap from the researcher's perspective. Today, we're hearing from the people who use the research. We're hearing about it from the policymaker's perspective. I'm joined today with three speakers. I have Jeff Fiebig, Chris Morris, and David Panter, and I'll introduce them to you in a little more detail in a moment. But first, I would like to acknowledge the traditional custodians of the land on which we meet today, their elders past and present. The concept for this series was initially developed with Carol Davies from SAMRI, Ellen McIntyre from PHCRIS, the Primary Healthcare Research Information Service, and also by John Carnan, of course, from University of Adelaide and Hazrans. I should say that my name is Christina Hagger, and I'm Senior Research Fellow and Manager of Knowledge Exchange at PHCRIS. The purpose of these series of meetings is twofold. It's to give us something new to think about how we can make our research more meaningful, how we can really have an effect on improving health outcomes. And the second important part of that is that we work so well in groups as we form our own communities of solutions. So what we want to do with these series is to bring people together so that they have an opportunity to discuss what they've been hearing and look about how they could create their own solutions. A little bit of housekeeping, perhaps, if I should. I believe the emergency exits and bathrooms are through those doors. This session may be being videotaped, and I'm sorry to be a little cautious on it. I understand that the recording was working perfectly on Friday night. Something happened, and now we're not quite conscious if it is recording, but we'll work on the assumption it is. Therefore, there will be time for questions. If you wish to ask a question, could you please wait for a mic to come to you, and then it would be very kind if you could please introduce yourself by giving your name and your organisation. The session will finish just before 10:30, and that will allow you time, if you could please, to complete the evaluation sheets that are on your chairs. We really appreciate what you say on those evaluation sheets because it allows us to improve the series and deliver more of what you're looking for. So we really appreciate your comments on that. Each of my speakers will talk for some 15 to 20 minutes on how they have used research to improve their policy or practice. So I'd like to lead now on to our first speaker. So she's flipping to her pages. And I would like to introduce to you Dr. David Panter. David is the Chief Executive Officer from the Central Adelaide Local Health Network from the Department of Health here in South Australia. David has almost 20 years' experience from across health and local government sectors in the United Kingdom, having been a Chief Executive in both. In October 2004, David was recruited to South Australia to run the Central Northern Adelaide Health Service. In January 2007, he moved into the South Australian Department of Health to develop the state's 10-year healthcare plan and lead the health reform process, including the development and procurement of the new RA, right down here in front of us. David became the Chief Executive Officer of Central Adelaide Local Health Network in September 2012, and in that role he is overseeing the transition to the new hospital in 2016. So it's a very, very diverse background from different countries that you bring to us, David. Could you talk to us about how you've used research to inform your work?
Thanks. I thought what I'd want to do is just sort of start off a bit just by giving some broader context, I think, because, and we were chatting about this before we started, that in some ways people do tend to have a view that within the health sphere, research translation into practice in clinical matters is relatively straightforward compared to when we try and look at that more in terms of policy issues. And in my experience, both are equally fraught. That, yes, absolutely, you get the big clinical breakthrough that capture the national and international headlines, where it appears a more smooth transition through to practice on the ground and integration into clinical practice. But for the majority, in my experience, it's not that sort of smooth process at all. There's a lot of, I hate to say this, but a lot of chance and luck in terms of who's sitting in what chair at the right time in the right place. And certainly if I was to bring together a group of, say, my orthopaedic surgeons within central Adelaide, they would each have their own view as to what the evidence base was that they were working on and their ability to justify which sort of prosthesis, a hip replacement or a knee replacement, they believed was the one that should be used. And so even where we have some very clear evidence, in fact, from the approach taken about what might be the most effective prosthesis to use, there's still enormous variation.
Of course. And
when we were, and I'm going to come back and talk more detail about the new hospital, but when we were looking at how to ensure that the new hospital was as flexible as possible for the future and understand what the lag time was in a South Australian context between research and the implementation that on the ground. It was still sitting, this was about 3 years ago when we commissioned a piece of work to look at this, it was still looking at around about 14 to 15 years was the lag time in clinical evidence being created and its introduction into everyday practice within our health services. So again, it's just to give a bit of context, because my view would be that it is difficult, therefore, to implement evidence-based research in a clinical sphere where you've got some potentially much tighter constraints around how that process works than within the non-clinical sphere. So it's even that much more harder to make that progress in policy research, in health service research, because it is even more open, I believe, to the individual viewpoints of those interpreting that evidence. And so, having sat as the chief executive of various organisations, probably in total now for getting on for almost 30 years, I can recall having lots of debate and lots of discussion about wishing to ensure that our service developments, our policy was evidence-based and informed by current research, but actually find it very difficult to see where it's actually had particular traction unless there was a particular champion.
Yes.
And if that champion also interprets and understands the broader political context in which a health service or a local government might actually operate. And that political context for people such as myself is absolutely critical, because so much of my work in actually shepherding through a health service, overseeing large strategic development within health services, is clearly linked to the political appetite or aspiration to actually do that. And that's very evident for me here within South Australia, because I think what we've seen happen over recent years in terms of the development of our own public health services and the development of the New Royal Adelaide as part of that is basically due to the fact that the stars were aligned, if you like, between what the politicians wanted, what community expectations were, and what was coming out in terms of research on an international basis as to what made sense in terms of developing sustainable health services. And if either of those elements hadn't been there, it would have been impossible to make the progress that we've made. And sometimes I sit there and think we haven't made a huge amount of progress, but when I sit down more, usually with a glass of red, and think more deeply about things, we have moved a huge amount in the last 10 years within the public health service here in South Australia. But it did take all of that alignment. And critical within that was having, as I've already mentioned, champions for their particular cause, but champions who could interpret their, in this case, their research in a way which enabled the rest of the system, be it managers such as myself or politicians, to actually hear that in a way which made sense. So I think there's a big challenge for researchers in how you can actually pitch your findings in that particular context, because the findings might be great, but unless you can actually pitch them in a way which grabs the attention and the sympathy of those decision makers, then it's very difficult to actually get the traction to implement. Some specific examples I wanted to focus on. I did want to go back to the development of the SA Healthcare Plan, which was launched back in 2007. And just say a bit about that journey and how the things which I think have gone well, the things which have gone less well. And then move on to talk about the new hospital. Part of the attraction for myself coming to South Australia 10 years ago was that the government of the day had a very clear view about wanting to reform the system. And they had looked across Australia to try and bring somebody into a key senior role within the state who would be able to apply some strategic thinking and some evidence base to that thinking to drive the reform agenda. People may recall there was a large review of the health services that were done back in 2002-03, which set out some, and again was well founded in terms of evidence and principles, but it was at that level of principles. So it said things like, we need to invest more in prevention and primary care if we're going to have an impact in terms of the way in which hospital services will just increasingly eat up the budget. So some very clear principles based upon evidence from elsewhere. But what that review lacked was the translation into a roadmap or an actual plan as to how to deliver those principles on the ground.
Of course.
And again, that's often in my experience the gap, and it's what I was referring to earlier on, between having the evidence and having a belief in that, but not necessarily having the hearts and minds of folk and the ability to translate it into meaningful action on the ground, which at the end of the day is what's going to get politicians' attentions. So the work began back in 2004 to look at how we translated the laudable aims of the Generational Health Review into that route map. And that's what the SA Healthcare Plan was about. It's what are the steps we have to take. And again, it's just interesting to reflect that regardless of the evidence, certain things at certain times are just too unpalatable for politicians to accept. So if I put my hat on as being somebody who, say, has worked in the policy sector within health for the last almost 30 years now, and I draw upon the evidence base that I draw upon, which is in health service practice, then it's very clear to me that whichever way you look at it, a population of the size of South Australia, of 1.5 million, indicates certain levels of health services, particularly hospital services, that should be provided. So I can mount a very strong argument as to why, for a population of 1.5 million, you only actually need one tertiary quaternary hospital centre. You don't need 3, let alone a 4th which specialises just in women and children's activity. You look internationally, whether it's in public health systems in places like Canada, New Zealand, Scandinavia, the UK, or indeed in private systems such as within the US, that in terms of getting the quality outcomes for particular sorts of treatments, then you actually need to consolidate those services, and you need to have them practicing in that consolidated way with a large cohort of patients in order to get those outcomes. So to make that very sort of explicit in South Australian terms, we only have in the state 6 neurosurgeons. They currently work on 3 different sites in 3 different teams, as well as in a number of private hospitals. And therefore, I can very easily construct an argument that says we don't necessarily get the best outcomes. We certainly don't get the best outcomes in terms of the use of the public dollar by them working in that way. But we end up politically with that split still because of the fact that our politicians still want to have at least 2, if not 3, tertiary quaternary centres, so the Royal Adelaide and Flinders, as well as protecting the women and children's, driven by community expectations of access to services. And that, to my mind, leads to a system which is not evidence-based and is inefficient and doesn't necessarily produce the outcomes that we could. Now, I'm not saying that to flip it round, I'm not saying that because of this we kill people inadvertently, but we could do even better than we are doing, and we certainly make better use of the public dollar. In terms of that shift into primary care, then again, lots of laudable aims about the importance of primary care. And I'm talking here about both primary care as provided by general practice, so general practice care, as well as primary care provided by a range of other professionals in the community and within the prevention arena. So that broader sense of primary care, both prevention and practice in the community. One of the things which I've struggled with over the last 10 years in that debate is, again, where's our evidence base for the way in which our GPs currently deliver their service? And there's a lot of talk in this country about our shortage of GPs. If you look at the evidence across the world that have similar general practice arrangements, then one of the stark differences in Australia is that the ratio that's described between how many GPs per members of the public you need is grossly different. And it's about half. So here, the view very much expressed is that it's about 1 GP for 900 head of population. The UK, I was in Scandinavia with the minister a couple of weeks ago looking at some systems there, Scandinavia, New Zealand, Canada, countries which have got similar general practice type systems. Their ratios are somewhere between 1 and 1,500 to 1 to 2,000 head of population. Interestingly, the figure of our 1 to 900 here is largely set by the College of General Practice as their view as to what is good practice. I've had many, many conversations with GPs in Australia over the last 10 years about this issue. Very often the argument's given to me that, well, GPs here don't practice 6-minute medicine. They look at you more holistically because they don't have that same demand in terms of number of patients. I actually can't find any great evidence of that in terms of access to GPs, in terms of appointment times. And when you look at the evidence around health outcomes, there's nothing to indicate that actually our health outcomes, because of that ratio, is better than in all those other countries that have similar systems. So, again, where is the evidence flowing through that actually enables policymakers and politicians to make informed decisions? How's that controlled? And at the end of the day, is there any political appetite to challenge? And again, don't wish to be misconstrued. I'm not saying that we don't have problems in terms of distribution of GPs, because certainly we do, because we know we don't have GPs in many rural and remote settings where we need them. But if we didn't have so many opportunities, given that ratio within metro settings, then we may well have a different way of incentivising GPs into those other rural and remote type areas and solve the problem we've got there. Likewise, from the work we did in the SA Healthcare Plan about looking about how you would actually change some of the way in which you could deliver that primary care service, and particularly the GP component, then again, the evidence from elsewhere suggests that you get most value for the public dollar by having some sort of capitation type model, rather than a fee-for-service model. Fee-for-service models create, they incentivise the production of widgets, and they create more and more widgets. It's fascinating talking to some colleagues now from the US, as I was a few weeks ago, from Utah, who, and this is a very well-established private hospital system in Utah, linked to the medical school, the university, etc. The American system very much has been a fee-for-service system that's encouraged them just to do more and more activity, irrespective of the overall outcome for an individual or for a community or population. But the introduction of Obamacare, which shifts for an element of the population to a capitation approach, so many dollars per head of population for an annual cost of care, even though that hospital arrangement was only now receiving 30% of its allocation through Obamacare as a capitation amount, it had, in the course of a year, had radically changed the way in which that set of services were actually undertaking their business. And they had seen huge expansion of primary and community-based health services, because now the organisation wasn't about producing widgets and getting paid for every widget, it was about producing a health outcome. And clinicians themselves could see that actually the better health outcome was by not using all that money in the hospital, but actually creating their own hospital at home programs, their own outreach programs, their own primary care services. And within 12 months, they'd seen a dramatic change in the way in which they did their business because of that different incentive of having capitation as opposed to fee-for-service. So again, I'm raising that because when I look around the world at a high level at health policy, isn't that one of the things we should be looking at rather than a co-payment for GPs? If we really are in strife around our overall financing of the health system across Australia. But I don't see where that debate is happening. That then brings me to a further point.
About 2 minutes.
Yep. So, which is about how we ensure that those champions are not just articulating their policy, their research practice into that professional community, but into the broader community. Because public expectations will gear politicians' reactions to what they believe can be implemented. And then finally, given time short, I did want to just mention that one area in which we can talk, I think, in South Australia very proudly about how we have taken evidence from around the world and put it into practice is in the design of that building being built just across the way there. The reason why we say things like this is a hospital which has never been seen in Australia before is because we have had the ability, we've had the political support and the wherewithal to actually scour the world, to look at best practice, to look at evidence around how to make hospitals work in terms of creating a healing environment, getting better health outcomes, making them more attractive for staff to work in and therefore perform well in. And that building and the design of that building brings together state-of-the-art advice and policy and research outcomes, say, from around the world. There is nothing going to happen in that building which isn't successfully working somewhere in the world, but at this point in time, it's the only building in the world which will incorporate all of those factors into a building. That then means that, and again, I can say more later when we get into the discussion about what some of those components are, but it does mean that we've got huge priority now in ensuring that our clinicians, our staff, are able to cope with the potential that their new building will provide them, and that the community can also respond to that in an appropriate way. And that gets us into a whole new raft of policy and research work about what actually enables change and change in practice to happen. And again, we were having the conversation over coffee about there's a lot of been happening around the application of manufacturing processes to change processes in terms of the lean thinking or the Six Sigma type philosophy. But actually what we're looking at the moment, which I think is the most exciting area of research practice and evidence around change, is that coming out of the application of design processes to change management. And so some very interesting work being done by organisations like the Design Council in the UK, who historically have been the folk who accredit a kettle as being ergonomically designed or whatever and putting their kite mark on things. They're taking the principles of the design process and saying, how does that apply to human services and human factors? And therefore, their technique is about bringing together a variety of different practitioners who actually have nothing to do with health. They may be anthropologists, they may be chemists, engineers, historians, who then do micro-observation of process, clinical process, patient engagement, and out of that discover and identify findings which lead to the development of prototypes, which might be actual interventions, they might be tools and techniques, and then prototype those, and then evolve them and see how they work and iterate that process.
We'll leave it for there for now, but what I think you've given us is some fabulous thinking about change management principles, the importance of community expectations, research and political appetite all being in harmony. And if we can harness those forces, we have some real potential to move forward. We've probably got time for one or two burning questions. Do we have a mic? Yes, if you wouldn't mind just waiting for the mic. Just two, if that's all right. And then any other questions we can pick up at the end. If you could please just say who you are and your organisation.
Tori Wade from the University of Adelaide, but what you said reminded me of my other job, which is consulting to the Flinders Telehealth in the Home project on its sustainability. So I'm wondering if your comments on moving the online health into the home with patients is part of your future plan.
I mean, absolutely, Tori. I mean, I think that that's the way we've got to go, but it's in order for it to happen, it comes back to those basic principles, because we've got to have community acceptance that is as good and probably, in my mind, better than the traditional approaches, because we need the politicians to support the development and expansion of those modes. Because my concern is that in tightened financial conditions, and we've got the state budget this week, and we've already seen the impact of the federal, there's a tendency to just pull back to what we've done traditionally. And so I think the progress we've made over the last 10 years in beginning to look at different modalities, different ways of engaging with community and patients in their own homes, in the community, I think is under threat now, because I think there will be a tendency to pull back, particularly if we don't draw on that evidence base about what incentivises good clinical practice. And I think the elephant in the room for me nationally is that whole issue about fee-for-service, because if people, and that's both for GPs and for hospital treatments, because all of Medicare is based on fee-for-service, and all it does is incentivise more and more of the same, not innovation, change, new practices.
Thank you. And I think there was one, yes, I think the lady in aqua green, sea green, thank you. And that probably will be only question now, but further questions at the end.
Hi David, I'm Michelle Evans from Cardiology at Central Adelaide. Funding is the biggest problem for us in terms of getting the outcomes of evidence research into our practice. So there's two questions to this, which is how do we, there's often a shortfall in funding, or what is cost effective across the country isn't actually affordable at a hospital level because we're not seeing all the savings. How do we work towards either getting the equiset value or the NMAR value to better represent what's, to help the hospitals get these new interventions in? And secondly, a lot of the research now is finding ways to help people that we couldn't previously solve, and it becomes just more and more of a cost pressure because we're not getting rid of anything as a result of the research. We can now save these people's lives.
Yeah. So Michelle, I think it's a bit similar to my answer with Tori, because I don't think the answer is ever going to align things like the activity-based funding model nationally and getting the price right, because it's about how do we incentivise teams of clinicians to work in the best interests of our patients. And the mechanisms we use at the moment, which is partly that sort of fee for service or fee for an equisep, without acknowledging that to change practice actually has a cost to it, gets us into a corner of just doing more and more of the same and not letting go. And you'll be aware of the work that's happening in cardiology to try and shift things, like just the amount of people with chest pain who come to the ED who end up coming into the hospital when all the evidence suggests that at least 50% of them are low risk and should be back out in the community within 4 hours, and then have access to an outpatient follow-up within 48 hours. So what we're doing in Central Adelaide, and I carry the risk for this, is moving away from that notion of there's a savings target to saying, actually, no, we are living in tight fiscal times. However, how do I shift the incentive to clinical teams and our clinical directorates to use the public dollar wisely? And I think we do that by not saying here's a savings target per se, but we say, actually, you need to be thinking about how to provide your business. That, yes, we've got to make some savings, but for the sake of argument, if you focus on a 3% reduction in your costs, we'll take 2 of that percent to feed the savings beast and meet our budget, but 1%, which for our clinical directorates like medicine at sort of $300 million per annum, 1% is a lot of money, you can keep the 1% to actually reinvest. Now, that's a technique I used when I first arrived here in the old central northern Adelaide 10 years ago. I faced a budget problem of that stage 20 million. In my first 3 months, we'd saved 5 million. That was the point at which I got rung by the then health minister, who told me to stop saving, because that would clearly indicate that Treasury had given us too much money and they'd take it away. And that is, and I was naive at the time, but that is the way in which Treasury here works. But that 5 million wasn't actually a saving, it was a saving on our core costs to invest in primary and community care for those particular specialties. So it's changing the incentives. And that's why, for me, I think one of the most exciting areas of research into practice at the moment is that change management, how you incentivize, how we enable people. Because I fundamentally believe, certainly in the public health system, that 99% of the people there are there because they want to go home at the end of each day feeling they've made a really good, positive contribution. They're not there just to make a dime or to, take advantage. They really want to get good outcomes. We've got to create an environment to enable them to actually do that. And at the moment, we mitigate against it.
That's a very good answer. Thank you. Our second speaker, if I may, is moving on to Chris Morris. And Chris is a health promotion consultant. She's worked in a range of public health and health promotion positions, including 10 years in tobacco control with the Cancer Councils of South Australia and also Western Australia. She is currently the Director of Health Promotion for SA Dental Service. She has a strong focus, and her work has a strong focus on reducing inequities that contribute to poor health, and on raising awareness of the importance of oral health in overall health and well-being. Chris also has another strand that she's going to weave through her presentation, and possibly more in the discussions, is that she was also awarded a Churchill Fellowship in 1997 and a Chairman's Fellowship in 2007 to travel to Canada to share best practice in oral health in children. So over to you, Chris.
Thank you. So I feel when I was preparing for this, looking back on my wonderful journey in community and public health, I was thinking about my three passions, and they are tobacco control, more recently, although I did start in oral health, and my Churchill Fellowship. So I thought I would have three streams to this and talk firstly about tobacco control and look back in history to see, first of all, how research really gave us the groundings for where we are today. So in the 1950s, you probably all know this story, that two men in the UK, a young epidemiologist called Richard Dole and his supervisor went to look at why there was an increase in lung cancer in London. Dole thought it was to do with the new tar that was going on down on the roads, and other people thought it was to do with air pollution. And what they found when they examined all of these patients, the common thread was smoking. So off they went to tell the world that smoking was the cause of lung cancer. That fell on fairly deaf ears, and oh my God, you can't raise the alarm bells that smoking, which everybody is doing, might cause such a serious disease as lung cancer. So Dole then went off and did some more studies on smoking and doctors. And he actually went on to conduct one of the biggest epidemiological studies known to the world, and continued that study for 50 years. So he looked at 37,000 doctors. And so his first little study around the doctors also confirmed that smoking was related to lung cancer. So in about 1957, a health civil servant, I suppose you would have called them in the UK in those days, complete with cigarette in hand, announced that there might be some evidence that linked smoking to lung cancer. Dole went on with his work, continuing to try and raise the awareness of lung cancer. But it wasn't until the 1970s that people started to pay a bit more attention to it. So this is what David was saying around political will, advocacy, interest. So here in Australia, a group of very dedicated people working across a range of sectors decided to take on the tobacco industry. Mostly that work started in the late 70s and the early 80s, but there were courageous people like Simon Chapman who went up on billboards and had the Muck Up campaign, so they really started to shake the cage about tobacco and its harms, as by now they also knew that it was not just lung cancer, but tobacco smoking related to all sorts of problems. So when I came to work at the Cancer Council in South Australia in the early 90s, this research was still the grounding for us, and more research that had built on that for us to start really taking a big policy push. So the first things that we did in Australia and South Australia was to get rid of tobacco advertising. In the 80s we used litigation around passive smoking. So we had to bring together a group of advocates and again people who were willing in the government to take on big tobacco. Because in tobacco control, you didn't only have apathy or people who didn't really want to see how marvellous your research was. You had a giant industry who was working against you. And one of the ploys that the tobacco industry had, and still does have, is to counter with furphy arguments. And they did have some level of truth, I suppose, by saying, well, it's not really proven, it's not really shown. And when I was at the Cancer Council, we did actually, not me personally, but God, I love using other people's research, find the gene that linked the smoking to the lung cancer. So that was fantastic. I guess one of our little mistakes in trying to bring that to the public's knowledge was that we used a campaign called P52, I think it was. It was pretty dreadful anyway. because we're trying to get people to understand that cancer caused this gene to kind of mutate, and then you got your lung cancer. Pretty useless ad, really, in amongst lots of really good ads. So you know the history of tobacco control in Australia. It's absolutely fabulous and continues to be built on research, really good research and evaluation. So in the Health Omnibus survey that is conducted in South Australia every year, we still have questions that test out people's thoughts around how far can we push the policy environment with tobacco control. Can we push, into people's cars? Can we push into dining? So I was just, look, I tell you, I am so fortunate to have been in this position over many years, but I was the project officer at the time who introduced smoke-free dining. So, again, you didn't only just have the tobacco industry fighting against you, you also had the restaurants and the pubs. So, we here in South Australia were the first to introduce smoke-free dining in Australia. Big move, and oh my God, the world didn't end. And good evaluation and monitoring was able to show us that profits didn't drop, that people still went out to eat. In fact, more families went out to eat because they didn't have to have their kids in smoky cafes and environments. So the tobacco control example is an absolutely marvellous example of research converting into policy, but it didn't come from just the researchers. It came from political will at the time and a strong band of advocates for push the boundaries, and those people are still around today. Heart Foundation and the Cancer Council have a coalition who really work together to try and keep moving on legislative and policy arms to make sure that tobacco control stays in place. And when you lose sight of it or you drop the ball, things like smoking rates rise. So, we've had less tobacco control money spent in recent times because of budget constraints, and we know we're flicking up on the smoking rates again. So it's a really tricky balance. We come then to where I began my life when I left school, which was into public oral health. And we had two marvellous epidemiology sort of stories when we were studying. One was about a young dentist in 1901 who went out to Colorado Springs when he graduated. And what he observed there later was to become, I guess, one of the most interesting preventive medicine or dentistry or public health areas, is that he could see these people in Colorado Springs had brown spots on their teeth. Pretty unsightly, a lot of them. And they had very little decay. So he contacted Dr. Black, who was one of the eminent dentists at the time, and they presented a paper in 1909 to a dental convention to say, we've got this funny little story here. We're not sure what's causing this, but we've got these people in Colorado Springs with no tooth decay and brown spots. Marvellous epidemiology study. And then Dr. McKay, our young dentist, went off to another community across the other side of the country and discovered this community also had brown spots. And he eventually found about 3 or 4 communities with the brown spots and no tooth decay. And he's been doing this for years and years. And in the 1930s, he is in a community where there's a company mining bauxite and aluminium. And they were particularly worried that he was going to blame the brown spots on their mining. So with a bit of self-interest, they used their fabulous chemists to actually look at the water and the levels of various chemicals in the water. And because they had superior ability to look at the chemicals, they saw that there was very, very high levels of fluoride, and suggested to Dr. McKay that he pops back to Colorado Springs and the other places where he'd seen the brown spots and see whether that was the same case, which it was. So what do you do with a piece of information like that? I mean, seriously, you've got brown spots, which are pretty ugly, and, no tooth decay. So along comes a fellow called Trendley Dean many years later, and he discovers if you play around with those levels, you actually get a nice level where tooth decay is reduced and there are no brown spots. So he, again, political will, convinces the city of Rapid Springs to put fluoride into the town's water at 1 part per million, and lo and behold, the kids' reduction of tooth decay over 10 years is it's more than 60%. So the outcome of that is we have this great information. We also have this fabulous evidence that says the people living in those communities didn't have any more cancer, they weren't being dumber than the rest of the population, there wasn't any more infertility. It's a great story. But we also have a group of people over on the other side of the path, what did we say, on the one hand, on the other hand, called the anti-fluoridationists, who couldn't possibly believe that that research was relevant, that it was fantastic, that it's absolutely grounded in many, many, many years of looking at harms and benefits. So we have used fluoridation now in Australia since the early 70s, and I think it's a really good grounding for public oral health. It's socially equitable and it's a great policy. So what I've learned from that, and what I learned from my early days in the dental service, is that public oral health services do tend to look a lot for research, and they also look to monitoring and evaluation of programs that they're running. So in my early days, I was part of a research program that looked at sugar or sugary foods being sold in school canteens. And what we discovered was that children in those schools where sugary foods were sold had more tooth decay. Oh, heavens above, surprise, surprise. Our policy response in those days, in the 70s I suppose, wasn't great. I became a person who was running around trying to stop schools selling those things instead of actually taking a big picture policy approach. I did try and have a settings approach by getting manufacturers to change to a canteen menu that didn't have sugar. You know, I am creative. If any of you know that I have some very crazy ideas all over the shop. So that wasn't very successful until we got a government policy which said, okay, red, amber, green foods, and we make a big difference in actually where we're going as far as introducing some policy. But one of our really good examples in the public dental service in recent years is I came back to the dental service in about 2002, and we had a public dental waiting list of 48 months. We worked with our colleagues over at ACPO, the Australian Research Centre for Population Oral Health, to say, what are we going to do about this? We've got a lot of people coming in for what we would call emergency care, so episodic pain relief. And what we know for a population is that if you do general dental care, you're going to have better population oral health outcomes. So the dental service and ACPO worked together to look at developing an algorithm so that when people rang in for an emergency appointment, it meant that it wasn't up to the receptionist to determine whether that person really was somebody who needed today's care or tomorrow's or 2 weeks or to go on the waiting list. And this is what David's talking about in using public funds in a way that's innovative. We don't want people to be in pain, and we had several markers that were, right now, these people have to be seen. But that algorithm, over a very short space of time, enabled the service to switch from an 80-20 emergency general to the other way round. So now we know that people are actually having more general care and having better oral health outcomes. So that's a really good example of partnering with research, policy and practice to enable you to actually get good population health outcomes. One more dental example and then I'll move on to the Churchill Fellows. We also partner a lot in our dental service with ACPO, but with other partners as well. And we've got a lot of programs running where we actually, first of all, look at an evidence base. We always go to the research first to see what's around. What is there out there that we can use? David described bringing, research from other parts of the world into the hospital over there. It's the first port of call for any of my programs in health promotion. What's out there? So we've done a couple of things in early years and aged care where we've actually found that there wasn't huge amounts of evidence, but what there was enough to spark someone like me to say, okay, UK, nurses are doing home visiting. They're having some really good health outcomes. Can we use that in some way with our nurses to improve children's oral health? And we devised a Lift the Lip program. But we've also had enormous success in the aged care setting, and Jeff will talk a bit more about this, where we actually have done some innovative implementation research where we've looked at older people, identifying their oral health problems, getting those fixed, and measuring what that result is. Is it I'm glad I can smile? Is it better for their oral health? Can they eat? But what we've found through improving their oral health is it's not only their oral health and their physical general health, their aspirations for well-being and mental health are actually much higher up on the ladder of well-being. So we've had a lot of success in using those research moments to actually give us some really good policy outcomes. On the reverse side, are we going to talk about the bad things now or later?
We've got 4 minutes. Use it as you see fit.
I will use one shocker from government where introduction of a policy for oral health had absolutely no basis in research, and that was the introduction of the teen dental program a few years ago by the Labor government. Apparently someone was at the dentist thought it was a great idea to send out a voucher for teens across the country to be able to go and have $150 worth of dental care, wherever you used it, private or public. And can you imagine how far that went, for maybe a checkup or some x-rays, but it didn't provide any care if that was discovered was what was needed. Shocking policy. And Queensland's reversal of their fluoridation platform is equally worse, much worse than the teen dental program. Churchill Fellows, my love. Churchill Fellowships, for those who don't know, provide about $20,000 to $25,000 worth of funding for people not necessarily academics or policy people to go overseas and research their area of interest. It means that you can be a composter who wants to look at better composting, or a wig maker or a lute maker, or you can be Colin Beer who went to look at pheasant farming. What it has given to Australia, and South Australia in particular, with these research programs is an enormous amount of innovation and creativity and moving us into just fabulous places. I was fortunate, mine was on tobacco control and peer leadership. And what it showed me, which is what the tobacco industry was saying, spend all your money on young people. And what my fellowship showed me was that we should not be spending all our money on young people to try and stop them taking up smoking, that we should actually continue in the way that we were, which is focusing on adults quitting, keep up the education, keep up your peer programs, but do not put all your eggs in one basket. And seriously, if the tobacco industry are telling you to put your eggs in that basket, you're not going to go there. So the Churchill Fellows it's just an enormous contribution to all sorts of practice and some policy. So an example of policy is a fellow in Western Australia had an interest in untangling whales that were caught in fishing paraphernalia. He's gone off, looked at around the world at best practice, and he's now writing international guidelines for how to untangle whales, because it's a pretty dangerous kind of job. So, I actually encourage you to have a look at whether that might be an appropriate place for you to go in your research, and whether that can then translate into policy and practice. So I might stop there, because I'm sure we'll talk about lessons later.
Chris, thank you, that's perfect. I'd love questions, but I think if we can, unless there's anything absolutely burning, if we could just hold questions for the moment, and then we'll have general discussion at the end. And I'd like to introduce our third speaker, Jeff Fiebig. And Jeff Fiebig managed the Australian Government Aged Care Program in South Australia from 81 to 85. And from 95 to 2001, he was Director of the South Australian Office for the Ageing. He was responsible for the development of many initiatives around ageing policy in South Australia, including the 10-year plan for South Australia in ageing and Moving Ahead, that was a strategic plan for the development of health services for older people. Jeff is currently working with the ACH Group, a not-for-profit provider of services to older people, and IBF, the Italian Benevolent Fund, and is on the board of the Aboriginal Elders Village and Community Care Incorporated. Jeff's most recent project has been the idea, the development, and the construction of VITA, a world-ranked, better practice, innovative, 120-place teaching aged care service that is co-located with the Repatriation General Hospital at Dore Park in South Australia. So Jeff, over to you.
Thank you. First of all, I want to ask a question. How many people have an aspiration to move into a nursing home? How many people have an aspiration to move into a nursing home? 1? 2? Well, I'll talk to you later, because you're the first 2 people I've ever come across who have actually said that their aspiration in life is to move into a nursing home. And yet, so much of what government in Australia does is to build its policy, aged care policy, around nursing home care. And yet, when Mark Butler did his round of visitations coming out of the Productivity Commission, very few people said they wanted to move into a nursing home. In fact, I don't think there was one. What they said they wanted to do was to continue living at home. And so we have this whole industry which is developed in aged care, which has been developed around a model of care which is not necessarily the right model. And that's come about in a number of ways. I can tell you a story that back in 1950, there was a general election going on in South Australia. There was an organisation called ACH Group, the organisation which I worked for, who built some independent living units for people who came back from the First World War and Second World War. And Bob Menzies came to South Australia to open this facility. And he promised a 4-for-1 capital subsidy for every building that was built, which led to a massive increase in the number of retirement villages, the amount of hostels, and the amount of nursing homes that were built. Now, if you think if he'd actually said, I'll give you a capitation grant, as David has suggested, where we might actually keep you at home and living at home, and we'll keep you well, and we'll keep you in good health, that may have been a much better way to actually go, rather than promising a whole range of buildings. Now, that practice about building buildings has continued to move on. And don't get me wrong, I mean, buildings are a fantastic symbol of things that you're doing and the way that you can actually progress ideas. But they also lock you in to a range of practices which might not be better practice. When you think about the age pension age first came about in Germany. It was built on the fact that they were going to give the age pension to people who were 60. Now, just because people died at an average age of 56 at the time meant that most people didn't actually get a pension. Most people actually died before they got there. But our age pension ages, time you get a pension has been locked in to that thinking about Bismarckian Germany for so long. And now when we suggest the pension age might actually be 70, people are screaming that, well, it's too young, it's, or too old, or wherever your view comes from. But if you actually applied the same thinking, the best practice, the better practice that Bismarckian Germany suggested, then we'd be retiring at 86. If you're a man, 88 if you're a woman. And so you've got to constantly question best practice. When someone says best practice, you've got to think, well, best practice the what? Or how can you improve that best practice? How can you make it better than it actually is? And so much of what's gone on in aged care, and I dare say health and elsewhere, has been fundamentally flawed by the fact that people only think about the summative form of best practice, not what might be a future form of best practice. And so when you actually start looking at aged care, you don't just look at the health outcomes for people, you look at the social outcomes, you look at the housing outcomes. And so much of aged care's work has been influenced by people who have done work for AHURI, the Australian Housing Institute. So much has been influenced by people like Di Gibson from the National Medical Health Research people. And so much has also been influenced by people like Hal Kendig and others who have concentrated a lot more on aged care. Also, we've been very influenced by the user rights movement that's come out of the disability field, and people like Wolfgang Berger and Michael Kendrick who've done work around some of the social outcomes for people and some of the normalisation outcomes. And so what you're trying to do is to actually develop a blend between the silos about what might be better practice into the future. The project VITA was actually talked about. VITA is a teaching aged care service that opened its doors 2 weeks ago, adjacent to the Repatriation General Hospital. VITA has been 15 years in the making. It started out with research that was actually done on some out-of-hospital programs that were being run by ACH and a couple of other aged care providers at Ashford Hospital. And what it was finding is that you could actually get people out of hospital earlier, and you could actually keep people out of hospital through better management of their chronic conditions and by just giving them information. The whole idea about giving people information so that they could make decisions about their lives, their lifestyle, was quite empowering. And when we actually went around and had a look at some of the international research that was being done, it was quite evident that if people got information and could be involved in the decision making and be involved in making their own decisions, then you're much likely to get better outcomes for people. And so when we had a look at some of the consumer-directed care movements that were started in the late 1970s and 1980s in the US and the UK and through Scandinavia, we started to see that, again, where people were given dollars, where they were given control, where they were given choice, and they started to make the decisions about their lives and how their lives would be lived, then the outcomes started to improve. And there were many people who were actually amazed at that. But yet all of us live that way in our lives, in most of the spheres of the lives we live in. We make our own consumer choices in shopping, retail. For those of us who have a good relationship with our general practitioner, we don't just rely on what the general practitioner says, we question the general practitioner. We take that advice and we do what we want with it in the lives that we live. Now, it seemed to us in ACH Group that effectively if you applied that sort of thinking to the way that you provide aged care services, then fundamentally you'd be able to change the nature of what was being done in aged care, and you'd make it, in a sense, much more controlled by the person, with the person being better informed and making better decisions about their life, their lifestyle, their choices. So what we did is we developed, back in 1999, we developed a thing called the Transition Care Program, which is about getting people out of hospital earlier. And that was up to about a 15-week program that we could run that took people out of hospital. We were also running a thing called the Acute Care Alliance, which was getting people who were in for short-term stays out from hospital earlier, saving around about 2 or 3 days with the short-term care. With the long-term care, we did some research using Professor Maria Crotty, who's the Director of Rehab at the REPAT, Flinders University, and she was able to show that there are 11 to 12 days which were saved on long-term care. So we took that information, we went along to the Commonwealth Government, we went along to the State Government, we went along to people like David, and we presented that research and said, well, look, if you really want to save time in terms of the bed days in hospital, you also want to maintain safety, and you want to basically get better outcomes for people, triple bottom lines all the way through, then you might want to start thinking about ways in which we can get people out of hospital or stop people going into hospital beforehand. Now, out of that research came the Transition Care Program, and that 10 years ago, we thought, well, why don't we actually do something which basically incorporates teaching into the practice? And if we incorporate teaching into the practice, then we'll look at ways we can actually also introduce research into the practice. And so we worked with the SA Health, and we also worked with Flinders University about developing this concept called VITA, which is, as I said earlier, a teaching aged care service. Now, that's meant to do a number of things. Firstly, it's meant to get people back home. It's where the people who don't want to move into nursing homes want to be. And for those two people who basically said that, look, we want to go to a nursing home, then don't come to VITA, because we'll find a nursing home for you, we'll find a nice bed for you somewhere, and you can go in there and you can do all the things that people in nursing homes do, which is mainly sit around and do nothing. But, you know, if that's what your life is, then that's fine. If you actually want to participate in life, if you want to get back into living, if you want to get back into where your family is, if you want to get back into doing things that contribute towards society, then come to VITA. Because what we'll do is we'll try and get you back to doing the things that you were doing before you had that illness or before you had that fall or whatever. Not only will we do that, but we're also going to save SA Health money, because we're going to actually do this in a way that saves at least 11, 12, 15 days per hospital visit, but we're probably going to save more than that into the future, because the better we get at it, the better we'll be able to do it. Not only that, we'll also change Commonwealth government thinking so that the Commonwealth pays for a range of state government expenses. And so with short-term care, we've actually got a policy initiative that is about to be implemented by the Commonwealth, which means that we'll be able to take people before they get to hospitals, when they're in general practice land or if they're in an aged care service, and we'll be able to put you through a course of strengthening or reablement or whatever that will actually keep you from getting into hospital, and will also keep you better, keep you weller, keep you whatever the terminology is, so that your incidence of illness is reduced. And so therefore the impact on the Medicare items, the impact on time of general practice, the impact on the time in hospitals, and all the health services all the way through will be reduced. And so we'll do that as well. But we'll also do some other things. We have, the Productivity Commission recommends that over the next 30 years, we're going to need another 750,000, nearly 1 million residential aged care facilities. Now, from the research that ACH has done, we reckon that 25 to 30% of those residential aged care places won't be needed. They're not your two, by the way. You can still go to your two. But those places will not be needed. Now, when you think that the difference between a residential aged care place and a community place is about $10,000 per year, and that we're going to be saving somewhere potentially close to 200,000 places, multiply that by $10,000 per year for 30 years or for however long we might be influencing a number of places, then you can see that there are quite massive savings there as well in a recurrent sense. But not only is it a recurrent sense, but also in a capital sense. Every aged care place costs around about $300,000 to build. So if we can save something like around about 200,000 places by $300,000 per place, it means that there's something in the vicinity of $20 to $30 billion that will not need to be spent on building residential aged care services, that we can actually spend that in other ways, which hopefully are about more prevention, hopefully about more reablement, more restoration, which will again further reduce the level of commitment that's required by our public health system. Now, all of those things basically add up, and so in that sense there are better outcomes for the person, there are better outcomes for the federal government, state government's bottom line, and there are better outcomes in terms of the time that general practitioners and others will need to put in to this system. But there's another benefit as well, because what we're introducing is also a teaching aged care approach. And so with Vita, we'll be taking in about 600 students per year, but extending that across not just ACH Group, but into aged care. And so adopting a philosophy which is not about the warehousing of older people, it's about the reablement of older people. And through that reablement process, creating a different future about what people might be able to do as they get older. One of the problems with better practice, or best practice, is that for older people, there's no best practice. There are more older people alive now than there ever has been in history. Right through all of history, there are more people aged 85 plus now than there ever has been before if you totaled them all up. And so where does your best practice come from? You can't have best practice if you've never had that sort of cohort in the sort of numbers we're talking about. And when we talk to older people, they don't tell us that their aspiration is to go and live in a nursing home. They don't tell us that their aspiration is to go to a hospital. They say they want to stay well, they want to stay healthy, and they want to know the things that they can do in order to be able to do that. And so they talk to us about, look, where's our gyms? Where's the fitness work that we get involved in? Where's the diets that we can indulge in? Where's the trips that we can go on? What's the contribution that we can make back into society? Where are the things for us to do? We can't play AFL football anymore. Where's the sport for people aged 75 plus? So they're talking to us about a future that has no past. They're talking to us about something that doesn't exist. And so we're in the business of actually trying to create these futures. And so you may have heard terms like encore careers with older people. You know, after you've done working all your life, what are you going to do when you're 70 and 80 and 90? Well, encore careers are fine, but is it really an encore or is it just another job? And so the whole issue, not only about creating a future, also involves creating the language that we can understand to actually use for this group of people. Because they don't want to be called older people. They don't want to be called people in their 70s and 80s and 90s. They don't want to be talked about as aged care or aged care recipients. They want to just be known as people, and people who will live their lives and do the things that they want to do in ways that they want to do them. I'll never forget when my mother, who had dementia, was going through she died eventually of dementia, but for 4 years she couldn't talk, she had aphasia. And the things we kept on coming across which were best practice. Things like, yes, you've got to lie back if you take your food. We were quite prepared to actually take risks around the fact that she wanted to continue to eat the things that she had eaten all her life with some of the textures and whatever. But no, we ran across a range of professionals who said that this was dangerous. We talked about this with Mum. She just wanted to continue to live a life where she could enjoy the foods that she enjoyed and not have this soft muck pour down her mouth 3 times a day because it kept her alive. We also came across people who would refer to me as a carer. I'm not a carer, I'm her son. The roles as a son were very different from what professionals were trying to line me up with as a role of a carer. They wanted me to wash her. Mum would have been devastated if I'd ever touched her body. The respectful relationship between me and her was about not touching her body, not knowing those intimate bits, and having the same relationship we'd had for 60 years. And yet so much of what the health professions and others want to do is to change the paradigm into what they see as the right way of doing it, rather than what the consumer does. And so in all that we do, in all the research that we do in ACH Group, we go back to the consumer and we go back to seeing what it is the person wants, where they want it, how they want it, where it's going to be delivered and who they want it delivered by. And most of that starts to change the way that we think about aged care, and certainly the way that we think about Vita. The paradigm of short-term care, reablement, restoration, the person in control, is the dominant paradigm which is coming through. And other systems need to start to recognise that. It's not about patient-centred care. Patient-centred care still implies a domination of the professional over the person. Mm-hmm. This idea about I'm in partnership with the person. My doctor is not in partnership with me. I am in control of what I'm going to do. I'll take the doctor's advice, but at the end of the day, it's my decision. That's what older people are telling us, and that's the way that our systems need to move. We've designed Vita around that concept, and the process of review, the process of evaluation of Vita will be really interesting. Because what we'll be doing is not looking at institutionalising the best practices of the past, but trying to build the better practices of the future. And those better practices are going to look very different from a lot of the practices that have gone on before. But what we're also trying to do is to take a workforce with us and to develop a research community around that particular role, that particular function, and where that future of something like Vita and where it fits in the health system and where it fits in the broader social system for older people, where that fits. Thanks.
Thank you very much. Thank you. Perfect Vita time. Thank you. Clearly there is no complacency here among our speakers. All are very much driven on engaging with the consumer and making sure that best practice is not taken as a given, but it is challenged and questioned by bringing together the latest research, the policymakers, the advocates, the whole team together. We have 10 minutes for questions, and that would give you then 2 minutes for your evaluations. So, because they are important, they help us to improve. So, questions? Gentleman in the front, Carol? Thanks.
Thanks. All those presentations were great. I'm John Foote from Adelaide Uni, and have a particular area and interest in this area. But my question, particularly to Christine in the public health area, two things. Recently, I think just before the Tasmanian election, Lara Giddings was mooting an idea of making smoking illegal for people born after certain dates. I'm not sure whether it did gain some ground, but I'm not sure, based on what you're saying, that probably wouldn't be a great initiative to take. And it's interesting to see that I'm not sure what proportion of effort is put into obviously trying to get those impulsive people that would start in their youth and get the older ones off. I thought it was more like the ambulance at the bottom of the cliff, sort of saying, we're going to try and, obviously we've got to get people to stop eventually, but I'm not sure what proportion of effort is put into actually preventing young people, I dare say plain packaging legislation and things like that. And on the other side of things, with your story with fluoride, are we going to suffer a challenge, particularly with the enormous consumption of bottled water and all the other filters that people put on their taps these days as well? Do we see that there's going to be a huge rebound in dental issues as a result of that?
Okay, a couple of things. I'll take first. Tobacco control advocates have never really pushed for a banning of tobacco. All sorts of things have been raised over the years, from prescription to total bans. And, you know, if you listen occasionally when I'm driving home to, what's his name, Peter Gers, will raise that. If you're going to, you know, pick on the smokers, bloody ban it and stop being ridiculous. I don't think that the community is in a position to take that line, and I think if you wanted to go down that line, it would have to have a huge community support. And I think some of the other public health measures that are in around tobacco control has already seen us come from quite a high base of smoking down to a fairly low base in South Australia in particular. As far as youth smoking goes, what we know is that if there are less adult smoking in the community, less young people take it up. And we also know that just educating people does not equate to behavioural change. And that's where a lot of that health education, health information needs to be supported by other things. So we can never stop talking to young people about the effects of smoking and the detrimental effects, but smoking is a very complex behaviour, so the uptake is really related to youth culture. Luckily less advertising now, but if we see that, for instance, the tobacco industry are talking about introducing a low cost cigarette, it will be really interesting to see the uptake of that, because cost is a really good marker for young people taking up smoking. The higher the cost, the less young people smoke, because they're the most inelastic group in society. So the measures that we've got in at the moment around public health, is, as far as tax, education, campaigns to reduce overall smoking, are really the basket of things that we have for young people and in the tobacco control area. You would never just rely on education, because it's too complex. It's way beyond that sort of stuff. Highly addictive behaviour. If you smoke up to about 100 cigarettes, that nicotine addiction starts to hit in fairly quickly. And so, the old stuff around free tobacco, discos run by the tobacco industry, didn't take long for young people to get addicted. But what we have seen here in South Australia is that less kids are experimenting and less are taking it up. So that's that. Now, what was your dental question, sorry? Oh, yes. We have seen some effects of bottled water. So where there was a massive decrease in young people's tooth decay in the 70s through to the 90s, as the big introduction of bottled water and rainwater tanks came back in, we have seen an increase in tooth decay. We have been trying to push for some fluoridation in bottled water, and certainly we would hope that the health ministers here in South Australia would stand firm on fluoridation, and we don't have a reversal as we do in Queensland.
Thank you. Other questions? Yes. Thank you. And then the lady in red.
Good morning, my name's Elaine Kite. I work upstairs on the 4th level at the Wadley-Paringa Aboriginal Research Unit. I was particularly interested in what you had to say, Jeff, on a couple of levels. First, you were talking about, you made a mention of Germany, age pension at age 60 when people were sort of dropping off the perch at 59. This is happening in our communities, Aboriginal communities and Torres Strait Islander communities right here and now. There are people who have, for those that have been in full-time employment, they're not reaching retirement age. We're all aware of disparities in health outcomes and life expectancy. And I'm particularly interested in what is available for those much younger Aboriginal people who don't necessarily have access to care, to caregivers, and for a lot of our people to actually make it to a nursing home is a celebration. So I'm particularly interested in those areas around what's available for Aboriginal and Torres Strait Islander peoples.
I'll let David come in on this as well in the health area, but I'm on the board of the Aboriginal Elders Village and Community Care Organisation, and so a lot of our work is very much directed at working with Aboriginal health organisations around ways that we can educate people but also provide services to people as well. We would probably provide at the moment services to about 450 Aboriginal people in their own homes across the metro area. There are other organisations that provide a range of country services, but the issue is very much around housing in early life, very much around children being taken away from their families in early life, very much around diet and other lifestyle factors. Smoking, I think, is certainly a big issue. So in lots of ways you've got to go very much upstream in order for people to have that aspiration about living in a nursing home. Not that I would suggest to any Aboriginal person that they might have that aspiration. They might want to get older, but they might just want to continue to live, work, recreate, all those sorts of things with Aboriginal people and other people as well. Certainly that's the aspiration of the Elders Village and Community Care Association, that the more we work with health organisations, the more likely it is that Aboriginal people will get older.
David, do you want to add to that?
No, fine.
No. Thank you. We have time for one quick question. I think the lady in red I saw first.
Green was up first.
Oh, all right, sorry. And then one quick question. Then, if we may, just one sound quick sum up from each of you.
Hi, I'm Kate Burns from Flinders University. Talking about smoking, I recall the direct action of Peter Walensky. He did two things in the 1960s. He was on the board of Qantas, and he managed to persuade Qantas to ban smoking. And then when he became head of the Public Service Board, and I have to say I bless him still for this, he simply introduced an edict that we weren't allowed to smoke. It was a terrific action for all of us who were trying to give up cigarettes at that stage. But that's a sort of by the by. I have my research work is in end-of-life care, and I keep being surprised at how people don't talk about death and dying well. I mean, we've found here in South Australia the very good news story that there's a huge number of young people who actually do, pitch in at the end of life and provide care. Grandchildren, nieces, nephews, friends. In the country, it's young friends as well as older friends. And I'm concerned that we're not introducing to younger people the notions of care. I mean, there's in policy terms, there's lots of talk about how to save money, but we're not really encouraging our youngsters to celebrate the love they may have for their grandparents.
Is that a question for?
Yes.
For Jeff in particular?
Yes.
You've got a very short time for a very complicated answer, so I'm sorry, you're in a difficult spot.
I mean, this is a topic that could take a whole seminar, really. Our experience is that people don't want to make advance directives themselves, that there's a dearth of people who visit older people in aged care facilities. And so the whole notion of death is something which our society doesn't deal with very well at all in a lot of cases, in most cases. And so the fact that if we can educate people about the notions of dying and whatever and what makes a good death is certainly a field which is open for lots of research and for lots of translating research into practice.
Thank you. Very quickly, because we have about 90 seconds each, between the three of you, what is a take-home message that you'd like to give the people?
I think for me it's not about unfortunately the quality of the research itself. It's about the adding to that in terms of the championing of it, picking your right time, and the tenacity to keep going. I can recall the amount of time and energy that went in around Vita in terms of all the things that have to be navigated and all the hearts and minds that have to be won over to turn that into a reality. So it's not just the research, it's all the follow-on afterwards.
Thank you, that's excellent. And Chris?
Well, I totally agree with that, and you need a great deal of patience and passion, and excellent research still doesn't get you away from the nutters, the naysayers, and the self-interested people who will challenge it along the way. So you need to have perseverance and persistence and a lot of guts in a lot of areas. So, and I just love it, as you can tell.
Okay, and Jeff, you have the final word.
You need to build up communities, as David said earlier, of people who want to do things. And it reminds me of a story about the chicken and the pig walking past a restaurant. They look in the window and someone's eating bacon and eggs, and the pig turns to the chicken and says, that's the difference between you and me. You're involved, but I'm committed. If you're going to be a good researcher, get committed. Don't just get involved, because it is a long journey.
On that note, thank you. Would you join me in thanking our speakers?